Hi everyone, welcome to the Medtronic live webinar today on COVID-19 and technology. So I'm really honoured today. We've got a number of speakers to join us. So I'd just like to introduce everyone. So we have Mike Wilson, who's the CEO of JDRF. We have Spiros Fourlanos, who's the head of Royal Melbourne. And we have Laura Zimmerman, who is the head of the ADEA branch for Queensland and also the convener of Private Practice Special Interest Group. So today we're going to talk to you a bit about COVID-19, about managing telehealth, and an update from everyone's different perspectives of how we can best treat people with diabetes and give them the best outcomes through this pandemic. Without further ado, I will hand over to Spiros to talk us through some of the clinical updates that have happened recently. Thanks so much.
Thanks very much, Lara. Specifically want to thank you and Medtronic for giving me the chance to participate in this webinar. This is something a little bit different for me because I don't normally talk about technology, but I'm certainly really keen to deliver this webinar along with Laura and Mike. I think it's going to generate a lot of discussion. So just to show you my disclosures, firstly, I'm the Director of the Department of Diabetes and Endocrinology at the Royal Melbourne Hospital. So I'll give you partly a perspective from a big tertiary centre in Australia as to what's happening with COVID. If we just move on to the next slides, they're my disclosures. In terms of the overview for this particular talk, we'll just move on to the next slide there. I'll be basically talking about some recent data on diabetes and COVID-19, some really interesting and important data which has just come from the UK. And then I'll talk about the context of diabetes with technology and telehealth, a little bit about the pre-COVID era, the COVID era, and then what may happen in the future. So in regards to the waves, now there's lots of discussion about infection waves. We've somehow managed to miraculously escape a massive wave in Australia, which is fantastic news. But as you all appreciate, we are anticipating that there may be other waves to come, and there's lots of discussion already about a second wave, and there's many possibilities. The reality is, many of us think that this coronavirus infection will wax and wane. Now, apart from the infection wave, we really need to have a strong appreciation of the medical waves. And when the coronavirus pandemic first broke, it was clear to us that we were concerned not only about the direct infection risk, but what was going to happen to people with chronic medical conditions such as diabetes. So if we just move on there to the next slide, there are four key waves of concern. Clearly, there's the first wave, which relates directly to the infection, morbidity, and mortality with SARS-CoV-2. But the second wave is that on urgent non-COVID conditions which have not been managed at the start of the pandemic. And what we saw at the Royal Melbourne Hospital, I'm sure many of our viewers will concur, there was an incredible lull actually in presentations to hospital, to ED, and people being admitted to hospital in March and April. And over May and June, we've seen a very rapid upsurge in people presenting with other chronic medical conditions, unstable diabetes, diabetic foot ulcers, people with myocardial infarcts. We've even had patients that had strokes who toughed it out at home because they've been too scared to come into hospital. And then there's the third wave, which is the interruption of chronic medical conditions such as diabetes, and there may well be a fallout from that. And clearly the fourth wave, which is already receiving some attention, which is the psychosocial problems, mental health has received a lot of coverage already, and the economic fallout of the pandemic. So if we just move on. Now, getting to the data from England, and you'll see here, now these are unpublished data, but I believe they'll be published very soon. They're from Jonathan Delovji and co. He's based in London, and they've assembled all the data from the UK experience, specifically in diabetes. And you can see here, these data are over the last 3 years, which is the number of deaths per week in hospital for people with diabetes, and massive rise in type 2 diabetes and type 1 diabetes, whereby you're getting over 5,000 per week people dying who have type 2 diabetes, not necessarily dying from their diabetes, but they have diabetes. So, really unfortunate graph of the rapid increase there in April. So if we move on, these researchers have actually drilled down and looked at all the risk factors for in-hospital death with COVID-19. And in this particular multivariable analysis, they have a lot of key variables, which one would imagine: age, sex, social markers, ethnicity, cardiovascular illnesses, and diabetes. And this is a huge data set comprising, unfortunately, 23,000 people who've died with coronavirus, and looking what factors are associated with death. And if we just bring up the summary for age, age is clearly a very big risk factor, especially the age over 80 group have already received a lot of coverage, with the odds ratio being massively elevated at 7. And certainly people aged above 70 are about 2.5-fold risk. And these are multivariable analyses which have adjusted for all other variables. And you'll see there, both type 1 and type 2 diabetes are independently associated with risk for death once the person with diabetes has contracted coronavirus and been admitted to hospital, with the odds ratio being 2.86 for type 1 and 1.81 for type 2. If we drill down further into the next data set, again from this research group, you won't be able to see all those data points because they're very small, and as I said, this hasn't been published yet. But if we just bring up the summary figure here, the message is with a multivariable analysis within people who have diabetes, you'll see there that the major risk factors are no surprise, but certainly very clear. Age above 80 with diabetes bestows an odds ratio of 4 for risk of death. A GFR of less than 30, so certainly chronic kidney disease is looming as a very important risk factor, and congestive cardiac failure and stroke. An HbA1c, which is high, above 10%, very high, so people with marked chronic hypoglycemia, and a BMI above 40, as well as male sex. So when you're having discussions and you get asked questions, and you may be asked by your patients or family, these are the risk groups. People who are older with chronic kidney disease and cardiovascular disease, who have chronic hypoglycemia and severe obesity. So if we just move on. Now, what are the issues in managing people during this pandemic, and especially people with diabetes without COVID? And that really is by far and away the majority of people, because we haven't had the spike in coronavirus cases that we anticipated. There has been a long-standing appreciation diabetes is a risk factor of bacterial viral infection. Influenza vaccination is very important. And it is important to emphasise that there is a risk of more severe COVID with diabetes, especially in the elderly and those with chronic hypoglycemia. And this, from my experience, is bringing up discussion. Well, should I be worried, Spiros? Should I be doing better with my glucose control? And certainly I'm using this as an opportunity to say, well, this is a good time to actually get one's house in order in regards to health. And it's important not to drop the ball with regards to managing all these risk factors: glucose, blood pressure, smoking, weight, etc. In fact, the argument would be we should be even more vigilant. Preparedness is very important, ensuring all our people have adequate supplies of capillary blood glucose strips and medication strips, and Mike may talk about that a bit later. There were some concerns around supply. Reinforcing the importance of general measures to avoid acquisition of infection. And physical distancing is just as important for those who have diabetes. And then the telephone and video telehealth options are really important for monitoring. Specifically in type 1 diabetes, we'll just bring up the box there. The ketone strips are really critical. We will be talking about sick day management. CGM devices can be very helpful for monitoring glucose, particularly in the context of intercurrent illness, and ensuring people have an adequate supply of glucagon. So we can move on. So that is some of the key points I wanted to emphasise for people with diabetes without COVID in this COVID pandemic. Now, should one of your patients sustain coronavirus infection, just some key messages from me. Have a real appreciation for the potential extreme lability in glycemia. This is a condition which elicits a very strong counter-regulatory hormone response, so insulin resistance can be very prominent. So the demand for insulin can dramatically increase, is what we're hearing from our overseas colleagues. Viral infection of beta cells can occur directly, so that could cause problems, including diabetic ketoacidosis, even in people with type 2 diabetes. Hypoglycemia should be thought about, obviously, with variations in carb intake. And there are some caveats. People are on automated basal insulin delivery systems, and in the context of severe intercurrent illness, these systems may not work very well, and people may need to revert to manual mode when using their pumps. Okay, now apart from the lability of glycemia, there's a sick day management, and I'm sure Laura will actually talk about this. There's obviously great importance to continue use of basal insulin, as I hinted, most likely increasing basal insulin, and never omit a need to adjust the prandial insulin, obviously based on carb intake, and intensive glucose and ketone monitoring, especially in type 1 diabetes, is paramount, and obviously hydration is really key. Now, close monitoring by the health professional team is critical, and this is why we're actually doing this webinar. Telehealth all of a sudden has become a fantastic option in this particular scenario. I also want to mention with technology, there are some caveats when we talk about continuous blood glucose monitoring technology. Have to be careful with severe tissue hypoperfusion. Interstitial fluid glucose monitoring may be inaccurate and not appropriate to use that, for example, somebody with severe coronavirus. Okay, so that's a bit about what's been happening in terms of literature and some basic messages. I thought I'd show you one case. We haven't had too many cases here. In fact, the Royal Melbourne Hospital had a peak of 14 or so cases in April, but in fact, we've only been sitting on between 0 to 2 cases in the last month or so. And this is somebody, in fact, who wasn't admitted to hospital. He had type 1 diabetes, but did contract SARS-CoV-2. And I thank Peter Coleman, who kindly provided the summary of this patient. So he was a 67-year-old with adult onset type 1 diabetes, diagnosed at age 36, who had an HbA1c of 7.1%, and he had a history of hypertension, hyperlipidemia. And you'll see from the first panel there, his glucose control usually without illness is very good, with most blood glucose levels between 5 to 10. We bring up the next panel. What you will see, hopefully, and I know the figures are quite small, if we bring up our red arrows, it will highlight to you there was a strong counter-regulatory hormone response. If we just bring up our red arrows now, just to the slide advance, there we will see that there's a strong counter-regulatory hormone response in the morning with the blood glucose levels trending upwards overnight and upon waking. So that's what we're hearing from overseas. You can anticipate there will be these periods of hyperglycemia reflected in insulin resistance. Okay, so hopefully gives you a bit of background of some of the key issues with managing diabetes in the context of this coronavirus pandemic. Now, I wanted to zoom in specifically on technology and telehealth in the COVID-19 era. And when I was thinking about doing this talk, it got me thinking about words. I do love my words, and with my name, as you can tell, I would have some Greek blood. And I was thinking about what does the word tele actually mean. It's actually an ancient Greek word, tele, meaning far or distant. So we're talking about completing something over a distance. We are completing healthcare over a remote distance. So if we move to the next panel, this is not a new concept. We have been doing telephone health for decades. Many of us will be familiar with the concept of getting dozens of calls and having glucose measures faxed or read over the phone and providing advice. Telemetry in the last few years has become very important. CGM devices allowing us to view people's data remotely by computer. And more recently, with the advent of video technology, we're now talking about what we call modern day telehealth, which is doing video consults. Okay, so if this is not a new concept, at the Royal Melbourne Hospital, we have introduced a form of glucose telemetry, which involves using a networked blood glucose meter system. This is the SAT strip device, which is now being used across the whole hospital, such that we can remotely monitor people's glucose control through a central point, through an electronic medical record, EPIC, which is a proprietary system from the US. So this all happens now automatically. Our EPIC system is going live in August, and there's no need for nurses to enter blood glucose levels onto paper charts or into electronic histories. This happens automatically. So we have a form of telemetry. So this is something that's happening in the community and it's coming to the hospital system. So when considering the different players with diabetes technology, it really starts to become a little bit complicated, because clearly you have the person with diabetes there in the centre, and you have multiple different healthcare professionals. Obviously, primary care is critical, diabetes educator often involved, and potentially an endocrinologist. But there's also other bigger players. Certainly, the hospital system, there's a real push for us to use telehealth because it's efficient. For example, the Royal Melbourne, our waiting rooms are not big enough now to have everyone with diabetes come to our clinic. So our CEO has issued a directive, and I think this will be happening across Australia, that we need to move many people towards telehealth care, at least during this coronavirus pandemic. So I think it's here to stay. I think the government actually really likes it because it sees it as being economically sustainable. So if we think about the benefits and challenges for the specific people involved, if we just advance the next slide, we might just see if we can bring up that next slide there. Okay, so the benefits now, look, I don't have too much time to go into all of this in enormous detail. It's just to springboard some thoughts and discussion. There are clear benefits for the person with diabetes. Safety in a pandemic such as this, the convenience, less work leave to come into a hospital or to a clinic, reduced costs, and clearly diabetes technologies lend themselves to doing telehealth, and it can be very convenient for family members who I'm noticing are wanting to sit into telehealth consults. Clearly there are some challenges. Those who have more social disadvantage or lack of technology access, starting to see people possibly being not as adequately prepared because it's sometimes a less formal medium to communicate, maybe less prepared for consults. I'll be interested to hear what Laura has to say about that, and possibly less social. Some of our people love coming in to see us face to face. From a clinician's perspective, if we just bring up the next box there, there's clearly the safety factor applies to the health profession as well. I think this is a very powerful technology to increase outreach and influence. So I think that is exciting. We can impact upon diabetes as a nation better by adopting these technologies. Intensive treatment is all of a sudden, I think, far more possible. We've talked about the technologies being assistive. And there are some challenges. There is a time where you want to physically examine, you can't do that. It can be harder to communicate. Sometimes you need more IT set up. Managing the waiting room can have its challenges sometimes. So we have to think about all those issues. And I think those issues also apply to general practitioners, for example, in primary care, which is just the next panel, which is very similar to what I discussed for the endocrinologist. In regards to diabetes educator, again, I won't touch upon this because Laura, I'm sure, will give us her perspective, as she's very experienced in this area. Just in regards to the benefits and challenges, we should think about the devices as well. So let's just bring up the CGM panel there. Clearly CGM is exciting because it offers safety in regards to decreasing hypoglycemia. It's a powerful modifier of behaviour potentially, and it may be safe to use in situations, for example, mild viral infection, mild COVID. I've mentioned to you it does have some challenges. It's certainly not registered for use in hospital in the States or even really in Australia, and it can be unreliable with severe illness, and there can be some technical issues, and obviously the cost is a big factor. With pumps, again, comes with many potential benefits, decreasing hypoglycemia with low glucose suspense systems and automated insulin delivery, etc., when used in conjunction with CGM. Fantastic for facilitating remote monitoring. We're getting CGM and pump uploads, but there are some challenges. Obviously, any device can malfunction. The costs of these are significant, and I just wanted to highlight that in hospital use, we have to be careful because automated basal insulin delivery, for example, shouldn't be used in certain situations like surgery. And then there's the device software. This is fantastic for a pandemic. It allows us to fast track our problem solving, generate reports to patients. So it's very, very powerful. We just might move on to the next slide. Now, what does the future hold for us? I think it's very clear the future holds increasing use of telehealth in ambulatory care, primary care, private practice. There's going to be public demand for this. It's financially viable and it has government support. Hopefully we'll have ongoing support. It's had support in the pandemic, and hopefully this will continue. There will need to be increased efficiencies in clinic setup to make sure we run telehealth systems well. Again, very keen to hear what Laura has to say. This is an important period for us because we're all starting to dabble now in this technology, and the lessons we've learned from this era will help us to run telehealth better. We also need to think about interdisciplinary collaboration. I think it's really important that we're talking to each other, all the different groups, to ensure there's no diminution in professional standards and satisfaction. I think that's important. And there's going to be an increased focus on diabetes technology use in hospital. I've already talked about network blood glucose meters we're using at the Royal Melbourne Hospital. I believe we're one of the first hospitals in Australia to adopt the system and integration with an EMR. We've talked about CGM potentially being used in inpatients. Eventually, we're not there yet, and there's a need to update hospital guidelines and policies. I might just give you a quote here. This is from a very well-known credentialed diabetes educator in the US. Healthcare is undergoing a digital reformation. Like any paradigm shift, this will be challenging for many of us. Telehealth is now embedding itself into diabetes care and education at a rapid pace. In the near future, e-visits will be the norm and not the exception. And Ponder wrote that in 2013. That's really quite prophetic because it's happening, it's upon us. So I thought I'd summarise. COVID-19, unfortunately, is associated with a very high risk of in-hospital death. It does appear the risk factors, elderly age, low GFR states, chronic kidney disease, a history of cardiovascular disease, high BMI, and high HbA1c. The tele-technologies have transformed diabetes care over many years. COVID-19 is resulting in a very rapid acceleration of adaptation of these telehealth systems to manage diabetes in a physically remote manner. To maximise the potential of telehealth and diabetes technologies, we're going to need to have very detailed practice setups, and pathways will be required. And this is going to need energy, time, and funding. So thank you very much to listening to and watching my segment, and look forward to hearing from my co-speakers.
Thank you so much, Spiros. I really appreciate it. We might move on to Laura to have a chat to you about some telehealth. Thanks so much.
Hi, everyone, and thanks, Laura. Thank you so much for having me. It's a wonderful opportunity. So my name is Laura Zimmerman. So I've been working in telehealth for about the last 8 years, and almost exclusively since the start of COVID. So there are a few appointments, of course, that must be face-to-face, but about 99% of my work. So we've had to manage that shift. We can go ahead to the next slide. So as you know, Spiros went over, there are many challenges and benefits to telehealth. So to go over the benefits, so ease of access. So I've worked for about 7 years in rural and remote Australia. I covered through McIntyre Health about a 1,000-kilometer radius, working with all types of diabetes, type 1, type 2, gestational. To go see an endocrinologist or even a CDE, sometimes even to get off the station to see a GP, it can cost thousands of dollars, hours of driving. And so telehealth has really been a powerful tool and a really great equalizer that that we've really utilized and we're able to use to improve patient outcomes. And you know, studies are showing time and time again that we are able to make healthcare more effective and efficient, and a growing body of evidence is showing, you know, that telehealth can support and facilitate glucose stabilization. As Spiros referenced, we're able to do, you know, more consults, more efficient consults, and we're able to prevent hospital admissions likely due to this. The other benefits, you know, that we're experiencing is that, you know, for patients through COVID who are self-isolating, they don't have to delay care. If they need to, for instance, upgrade their insulin pump, we are able to do that remotely. We are able to do CGM starts remotely. There isn't too much that we can't do over telehealth or facilitate to be done. So it's been able to take down that barrier. Next slide. So some of the barriers. So I work with a variety of communities, a variety of you know, people with diabetes that I work with come from a variety of socioeconomic circumstances. So whether or not they have access to a smartphone or a video device, if they have access to internet, a quiet place to speak, The ability to upload language, intellectual or developmental disability. I was speaking to Jane Lehman last week. She's a fantastic CDE in South Australia. And she made the excellent point that if you change your mindset to where it's possible, to where this isn't a barrier, it changes how you look at the situation. It's no longer a problem. I work with Indigenous elders out in Cunnamulla, and they're able, to go into the local health service, and we're able to utilize a team, and we provide a very robust service. For my patients who don't have access to internet, we do phone calls. So there's quite a bit that we can do through telehealth. If they can't upload or send me their glucose readings, then they often go into the local pharmacy, who fax them or email them through to me. So there's often a solution. Next slide. So so what I find really interesting when I myself am at webinars is when people sort of lift the hood and they kind of show what they do in their practice to make it efficient. I've worked for a long time in McIntyre Health to make it a paperless organization and to work on systems, which has helped us prepare for COVID, although it still was a transition to change 60% face-to-face clinics to 99% telehealth. And so these are some of the tips that I've learned for managing patients and managing that transition. One of the questions that was sent through was attendance. So one of my biggest tips is to use your automated messages as much as possible, both text and email. You can create hyperlinks to education, to any PDFs that you have explaining telehealth. We have separate SMS and emails that go out for our pump, our CGM starts, or for our different appointment types that have specific education that's attached to each message. Next slide. So one of the biggest issues that we had was that, or one of the biggest barriers is people thought that telehealth wasn't for them, or they thought that they couldn't do it. And so I'm really interested in barriers because, I'm a big believer that they can be surpassed. I was trying to figure out why. And a lot of it was just because it was unknown, that they didn't know what the journey looked like. So what we did is we developed really clear patient pathways so that they know what was happening before, during, and after. And we answered the common questions beforehand. So my biggest advice is when you have patients who say, no, I'll wait till face-to-face, and you know that they need to be seen. And so that care isn't delayed if a face-to-face is not possible. Make the patient journey clear. What does it look like from start to finish? How does a patient prepare? So something else that Spiros, alluded to, I had a telehealth appointment this morning, and I was speaking to her, and it was quite loud. And I said, "Oh, is this a good time to talk?" And she was out at morning tea with the ladies. So that's not a good telehealth appointment, and that's not a good place to be. So we talked about what a good environment and a quiet environment and what it looked like for next time when we rescheduled. So there's preparation in that sense. Next slide, because I think we can talk about more how we prepare in terms of remote monitoring. But also, when you're doing telehealth, I think it's really important, not just for the specialists and the endocrinologists on this phone call. I work with multiple tertiary facilities across Queensland and across New South Wales. You can use the CDE and the local health professionals in the areas that you're telehealthing to help you. So often, at the moment, I do a lot of work with the Gold Coast Hospital when I'm out in St. George and Gundawindi and Inglewood, and I work very closely with their CDE team, kind of as a foot on the ground. Whilst I'm private and they're public, we have a synergy and a communication pathway that allows us to create a holistic service. And so I'm able to give them a bit more of a background information of the patient's day-to-day life. Next slide. So remote monitoring. So what we've tried to do is we tried to create a smooth system for each person with diabetes who visits our practice and how to get us this data. Next slide. So we use a combination of different programs: DiaSend, LibreView, CareLink, Dexcom, and the software that we use is Clinic to Cloud. And the reason for that is multiple reasons, but also because we have a patient portal. So when we're seeing a patient, and through the process of already being paperless, We have the report, we often have a separate screen that we're reviewing the report on so that we can still focus on the patient, have a look at the review so we're not switching from screen to screen. And we're able to save that report through the middleware directly into their file. So there's no printing and scanning and work for reception or things getting missed. Additionally, so if there's a PDF that, a My Life PDF or, a BGL upload, the patient has a patient portal that we use that they can upload this directly to that goes into their file. And so what we find is that as much information that we can get, of course, before the appointment, the more effective our appointments can be. So we've worked very hard to make sure that we have this process. Next slide. So strategies if a patient is struggling. So next slide. There's many different ways. So I come across one of my biggest problems is either getting a copy of their BGL book scanned and emailed to me if they don't have access to a computer, or pump uploads. Those are usually my biggest problem areas, but there's lots of people in the communities of where you're telehealthing into that can help. There's often plenty of pharmacists around the country who have a very keen interest in diabetes and who are very happy to have the patient come in and engage and do the pump upload and notify you when that's been done. The practice nurses at each practice or the Aboriginal health workers are very happy to be upskilled. Through my telehealth experience over the last 8 years, it's become very apparent that education really is a tide that lifts all boats going through this process. So as I'm upskilling the team around me and teaching them about these devices, how to upload maybe a bit about the reports along the way, it's all to the benefit of the person with diabetes at the end of the day. GPs are very engaged, nurse navigators, so you use every member of the team that you can. Next slide. So online tools, I find telehealth excellent. So if you don't have a dietitian that's near you, the Type 1 Diabetes Family Center has developed a very robust cyber carbs program. It can be education for health professionals, but also for people with diabetes age 12 and above. I highly recommend it. It's fantastic. I work very closely with Diabetes Queensland with their Western Queensland CDE project. So obviously I'm quite biased, but I find that they have a very easy to navigate website and fantastic resources. And so I use that as well. Also on telehealth, I often share my screen. Sometimes we have PowerPoints available, or we go through the PDFs together. And we can also send through information. So I think, having those tools ready to go before you're like a kind of a preset, stash that you have is really useful and makes for a seamless appointment. Next slide. So who does telehealth work for? So I think, I think that the answer that I'd like to give is everyone, but that's not true. What I would like to do is I'd like to encourage the people listening to this webinar is expand your thinking of who telehealth could work for. Do you have to be on the first appointment? Does that have to be in person? If you have someone who's, on a station and, or if they're out on a farm and it's planting, like, do they need to leave right then to have that appointment? Do you need to delay care? Or can you adjust your treatment plan? So I think, for people with, intellectual or, other disabilities, is that really a deterrent to do telehealth? If someone has a, hearing impairment, is that a deterrent? Are there solutions around that? So I think what we're finding, because we have been forced to innovate through COVID, that there really isn't much exclusion criteria for telehealth. However, that telehealth will never replace face-to-face visits. And I don't think that the question has been asked quite a bit and it's often been brought up. I just don't think that it's possible. There will always be a place. There's things you just can't do over telehealth. Next slide. So as I said, I think it'll always come down to clinical judgment and patient preference, for face-to-face review, but telehealth is definitely here to stay. And I do agree that, definitely as of 2020, we can now confidently state that we're entering into the 5th generation of personalized diabetes care. And I love this paper. But through telehealth, we're able to create for across Australia, no matter where you live, you're able to see the right clinician for you, and you're able to get prompt and appropriate, care wherever you live at the access and at the time that you need. So thank you.
Excellent. Thank you so much, Laura. Really, really appreciate it. We might just move over to Mike to have a bit of a chat to us about JDRF.
Thank you so much, Lara, and also to my fellow panel members. It's all too rare that the patient, the clinician and the CDE get together in places other than a clinic. And so for you to bring us together here today is terrific, and hopefully a benefit to the people listening to this webinar as well. A couple of comments from our perspective. As JDRF, we are effectively a manifestation of the passion of patients for better support and ultimately a cure for their disease, which is no surprise to many of you. Some reflections from that perspective. I think some of the matters in relation to COVID-19 have really caused deep fear in patients. Some of that fear is well informed, and some of that fear perhaps is not as well informed as it could be. Numbers that relate to relative risk ratios for certain outcomes if you catch COVID-19 are terrifying, can be horrifying and look really bad. But the absolute risk is still much, much more constrained to factors that you can't manage, like age. So I'd really like to encourage the listeners here to think about making sure that information provided to patients reflects the things that they can control and not the things that they can't, and adjusts in describing them for which are most important. It is a difficult time where people have felt management during this period quite challenging. And I think the move towards increased access to telehealth is terrific. I support all the comments that have been made about the benefit, the importance, its potential enduring impact on the health system. I do, however, think that there are some matters beyond just the provision of reimbursement for the service that we need to continue to address. And that is that a number of patients still don't have access, not just to the connectivity, but to the devices that underpin a large proportion of easy telehealth or well-connected and integrated telehealth service provision. Pumps, sensors, all of these things that can enable, for some people, much more effective management are things that we're seeking to make sure are more broadly available in partnership with our professional bodies and professional partners in representing the government. So access and reimbursement remain important issues. We've had some successes. JDRF runs the insulin pump program targeting more socially disadvantaged and financially, economically disadvantaged families. And there's the CGM access program, which in partnership with a range of organisations has produced some terrific access outcomes, but they're only a marker towards broad-based access across all. In the end, we need whatever technology, be it available now or coming down the pipeline in the future, to be available to people regardless of their circumstances, dependent upon their professional clinical advice and their personal need. We're not there yet. There are age distinctions, there are clinical criteria, and that's not good enough. But we should celebrate the fact that we have made some progress towards better access more broadly, and that is benefiting a large number of people. And it's particularly relevant with the sort of systems that Laura mentioned that can aggregate data and make it easier for health professionals to support patients during these times, whether it's remotely or in person. I think more broadly for patients, there should be a feeling of opportunity as well as a feeling of frustration. And we really encourage people to get involved and help us address some of these challenges that we're seeing as important foundations for future effective access, future effective management, in conjunction with the work being done by people like Spiros and people like Laura. We provide a vehicle by which people can take a hand in their own future. The changes that we've helped galvanise through governments, through reimbursement, through health system change, have only been possible because people have stepped up and told their story to decision makers and compelled them about the urgency to take action. This is very much complementary to what happens in the clinic. It's not an alternative at all, but it is a way to get actively involved. So I encourage people to think about, as their patients are speaking with them about options for their activity into the future, taking a role in helping make things change is also an important part of the future. We'll also provide a range of ways for people to connect to their community. We have a range of support services and information. Many health professionals provide access to our point of diagnosis packs for newly diagnosed families, both children and adults, with slightly differentiated offerings. And we also have peer support and online support functions for things that are not medical, not designed in any way to replace professional medical advice, but it can provide some of the personal access to someone who understands what you're going through with a child of perhaps a similar age, who's been on perhaps a similar journey, maybe a few months or a year ahead, and can talk to you about things beyond those things that you should deal with your health professional in the clinic. These are our community programs. They bring our community together, particularly in the case of type 1 diabetes, which is our focus, but also relevant to other diabetes organisations like Diabetes Australia for people with all types of diabetes. In looking to the future for us, it's really important that our activities as JDRF reflect the needs and interests of our type 1 diabetes community. So we're going out to ask the community what is most important for us to focus on next. There will be challenges. There are changes to the way the health system works. There are changes to the abilities you have to access support and services that were available before a COVID-19 world. There will be changes to the budget. There will be changes to fiscal constraint. But one of the things that won't change is the deep and abiding desire that anybody affected by diabetes has for better management and ultimately the removal of the disease. And so while you deal with and work through some of the challenges that come with this new environment, some of the opportunities that Spiros and Laura have described to you, I encourage you also not to lose sight of that enduring passion to make sure things change in the future. That we have the access, we have the reimbursement, we support the workforce, and we fund the type of interventions that can bring the best professionals, the best support, the best devices, the best therapies to give to every patient what they need at any point in time. And that's where JDRF can play a role alongside the medical experts that we're so fortunate to have in this country, that many countries affected by COVID-19 don't have access to right now, and that we'll continue to aim for over the weeks and months and years ahead, COVID-19 or otherwise.
Excellent. Thank you so much, Mike. I really appreciate it. And thank you all for giving your perspectives. During the course of today, and obviously just before, people have been sending some questions through. So I'd like to actually put some of these questions to you and discuss them as a bit of a group from each of your perspectives. So I guess something that's really come out of today was we've heard a lot from the health minister, and you have all spoken to it, of people who've maybe been delaying their regular appointments or their pathologies or things like that. Are you seeing an increase or decrease in attendance or in people staying on top of their day-to-day management? And how would you encourage our physicians and our patients to ensure that they don't lose sight of keeping their regular management in check during this crisis?
Yeah, I might start. I think, Lara, it's clear in Australia, the issues related to the pandemic are different, for example, to the UK, where there's been, unfortunately, a lot of morbidity and mortality around coronavirus with diabetes. Here, it really is all about people ensuring they continue to manage their chronic medical condition, diabetes, optimally, and that means maintaining contact with your healthcare professional team. So that is a critical message. Mike and Laura and us were talking about this just prior to starting on the webinar, so that is absolutely critical. I think reassuring people that the nation is doing very well in regards to addressing the pandemic, and the measures of physical distancing and the safety measures already in place are in place in hospitals, they're in place in general practice and other primary care facilities, and just making people feel safe that if they need to physically attend, they can. And now we have this extra dimension with the telehealth care.
Absolutely. I think initially for, I mean, we all have different patient sets, but I think, the people with diabetes that I have been working with, especially, it seemed to be more of my rural patients. They had just initially that there was a lot of fear and a lot of unknown, very understandably, but a lot of the people I was working with, they just stopped going to the GP, stopped following up on a blood test or two, almost terrified to go to the pathology center. And so a lot of the work that we did initially was just to reinsure with the right information, with the accurate information. But it was not so much an issue now, but initially it absolutely was. It wasn't necessarily that they weren't managing their diabetes, but they weren't going to their scheduled appointments.
So there are many times over the years in the globalized world where living on a large island a long way from everywhere has been a difficult thing. This is not one of those times. We are extremely fortunate to be in the country we're in, with the health system we're in, with the health professionals we're in, with the profile of COVID-19 that we have. Given all that, I encourage the health professionals and the patients to continue the routines that we know have been established for their optimal care and outcomes. There are concerns, obviously, that compromise that and conflict with that, but they've been managed in Australia better than almost anywhere else. And so a return to managing the things that you can do with your health professional in relation to your condition is timely.
And more specifically, if we're looking at mental health, there's been a lot of talk of that recently in the news and a lot of packages that are coming out. And we know that diabetes burnout is so prolific anyway in the community, let alone the burden on top of now knowing that you're at extra risk factor if you contract COVID-19. How are you managing the anxieties? Well, I guess, are you seeing the anxieties? How are you managing the anxieties, both as healthcare professionals and as organizations? And again, if there's any messages or anything that you found that's been really useful that you could share, be really helpful. Spiros, would you like to start us off again?
I think Laura,
go for it.
Sure. What I found again with the people with diabetes that I work with, and I have to say, Mike, the JDRF put very powerful resources that we absolutely utilized and shared and referenced. And it was a fantastic source of reassurance and accurate information, and put in a succinct way that was easily able to be understood. And often I would pull up those resources and I would go over them with each person and their family, because often, it was a parent concerned about their child. And one of the, the most powerful things I find in any situation where you feel helpless is to provide power over things that you can control. So a lot of it was sick day management, making sure everyone had a robust sick day plan, that all of their questions were answered. They had their glucagon, they had their ketone strips, they knew their plan, that all of that was nailed down, and just made sure that they that we had our next appointment booked. And if it went beyond that, if I felt that it needed to be escalated, one of the challenges that I didn't discuss, with telehealth is when you're not down the hall from someone, case conferencing can be, just that much, a little bit more complex. But, getting on the phone with the GP, or, including it in your letter, making sure you have, team conferences with the patient, patient's permission. But just saying, hey, I think they're struggling. What local resources do we have? And is a mental health care plan appropriate? And encouraging that person or that family to access those resources, but reassure them along the way has been our approach.
Yeah, look, I'd agree. Just a quick comment. I know we're running a bit short on time, but it's a blend of realism. And some of that UK data is real for the UK, but it is important we show leadership and to all our people with the condition. There's plenty of room for hope and optimism, as Mike said. The nation has a very solid healthcare system, and it's about giving our people a real world view of what's happening in Australia. And I found me saying, look, I've had only 2 or 3 people with coronavirus, and we have hardly anyone in the hospital with it. And the reality is there's many things you can do to treat and address it, rather than focusing on the high risk groups and really emphasising that. And we need to be aware of those high risk groups, but we don't want to emphasise and concentrate on that message, because there's plenty of hope there.
Mike, we've had quite a few questions that are specific to JDRF. Obviously, the whole research community is focused on potentially finding vaccinations for coronavirus. Is that impacting at all on the path to a cure for diabetes? And just as an organisation with the economic impacts, is there a risk to the future of JDRF and your research and ability to support patients into the future in Australia and globally?
So it's correct to say that a large proportion of research endeavour is being put towards the coronavirus vaccine. But let me assure you that a significant proportion of research endeavour remains committed to a diabetes vaccine. and to diabetes treatments and to immunology and to other factors that relate to either better treatment, prevention, or a cure. That is the reason we exist. Many things have changed, but our desire, intention, and absolute commitment to ridding this world of type 1 diabetes remains unchanged, and along the way to preventing it and to enabling better treatments, not just in their development, but in their access. Now, there will be some challenges in the short term where fundraising will be impacted, but thankfully we've also encouraged others, industry, philanthropy, government, to invest of their own monies. So while we try and change and adjust our fundraising portfolio, we'll still have the ability to invest significant resources in ensuring that researchers remain focused on these tripartite challenges affecting prevention, treatment, and a cure. In fact, in other countries, there are researchers who are without support given the economic circumstances they face, and there are people who have excellent skills that could be transplanted into the diabetes world that are bereft of things to do. So we're going to steal them, and we're going to make sure that the best brains are applied in a way that remains of great benefit to diabetes of all types, in a world where Australia is doing well enough to enable that to happen slightly more than some other conditions. So challenging times, fundraising still needs to be addressed, but lots of good things to look towards and some opportunity would be crazy to miss.
Amazing. And do we have any possibility of having a socially distant walk to cure diabetes this year?
So there's been a number of things we've had to rethink. Our gala balls, as fun as they are, have not been able to progress this year. And even the walks, they're some of the largest public fundraising events in Australia. And so we'd be hard put to say we're sure they can happen. So we're looking towards this year a slightly different model that might have to be an adjustment given current circumstances to make sure that people with a passion to do something still have an outlet, but we don't require the ability to bring large groups together. We'll find other ways to do it. We'll connect people. Connection is an important thing. But as the telehealth example has shown us, connection doesn't have to be face-to-face. It doesn't have to be in the same room. So the fundraising will continue. And anybody who can help us deliver on that, including through our Giving Day today, June the 11th, will be greatly appreciated.
Amazing. Thank you so much. So just conscious of time, I've got a last question for all of you, largely around telehealth. So obviously, we've spoken all about that, and we know that come the end of September, the MBS funding is potentially going to end. What can our healthcare professionals do? What can our patients do, and industry and all of us working together do to advocate? Because it seems like from talking to all of you, that's a really fundamental part to connecting with people with diabetes. So have you got any advice or any strategies, and also from your various groups and organisations you belong to, that we can get people to be more involved and advocate for?
It's a great question, Lara. I partly represent the Australian Diabetes Society. I'm the Honorary Treasurer. We've got Laura here is part of ADEA, and Mike from JDRF, and maybe we really need to orchestrate a mail campaign to our MPs from all the health professionals and the people with diabetes to say, look, we have started to use this technology more. It has been invaluable and incredibly assistive in this pandemic, and it is vital that it continues.
I couldn't agree more. I think a simple and clear message delivered repeatedly from the mouths and notepads of people who are infected is what changes policy. And we will develop a campaign, and we're working terrifically well with all of the diabetes organisations Spiros mentioned.
Obviously, yeah.
Yeah, but in the meantime, if you want to know what to do, represent your views to the Health Minister and to your local MP. Do it on the phone, do it via email, do whatever way. You'll knock on their door, tell them that if you believe it, telehealth needs to be sustained. We saw 10 years of change happen in 2 weeks. Let's not lose that.
And in terms of the ADEA has developed a survey for CDEs to discuss their successes and their experiences around telehealth that will be collated and presented to the Minister of Health. We also have developed a survey for the people with diabetes that we work with to fill out to discuss their experiences as well. Before telehealth started, the CDE executive branch of the ADEA, we put together CDE Telehealth Now GoFundMe petition that I think all of you signed. And, we have thousands of signatures. So I think, we are, as a community, we are so strong. And I think we need to make sure that, as Spiros and Mike said, that our voices stay united and that we don't give up, and that we keep fighting, and that we know that we have power and don't forget it. And I think this will continue.
Excellent. Well, thank you all so much. Did anyone have anything that they wanted to add before we end off today?
Just thank you to you and to my fellow participants. It's been good to be able to be on the same panel together.
Yeah, thank you. Likewise.
Thank you so much. We really have appreciated all your views, and hopefully it's given everyone a really nice, robust understanding of some of the changes that are happening. So thank you so much to everyone, to all of you for joining, and thank you to everyone for watching. We really appreciate it. And to all of our speakers, thank you again for being on here today.
Fantastic.